Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Sarah Fineberg will present Quantifying Difficulties in Social Interaction in Borderline Personality Disorder. The Brain and Behavior Research Foundation is committed to alleviating the suffering caused by mental illness by awarding grants that will lead to advances and breakthroughs in scientific research. The Foundation is the largest private funder of mental health research grants. Since 1987, the Foundation has awarded more than $380 million to fund more than 5,500 grants to more than 4,500 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists who are working to find breakthroughs in disorders such as addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, and schizophrenia. I'm delighted to introduce Dr. Sarah Fineberg. Dr. Fineberg is an instructor at the Yale Department of Psychiatry. She was a 2014 Foundation Young Investigator grantee and a 2015 Clairman-Friedman Awards honorable mention. Today's webinar will begin with Dr. Fineberg's presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. Feel free to submit your questions throughout the presentation. Following the presentation, I will ask as many questions as time will allow us to ask. And now, I'm pleased to introduce Dr. Fineberg. Sarah, the floor is yours.
All right, thank you so much. I'm just Nico, my screen has changed. I'm not quite sure.
Yes, so at the bottom, if you can click on the PowerPoint just to open it.
Do you want me to turn on my webcam now?
Yes, please.
There we go. Okay. Here we are. Okay.
Okay, and presentation.
Well,
Perfect.
I'm very grateful to be here today talking with everyone about borderline personality disorder and borderline personality disorder research. I'd like to start by thanking some of the many people who've been helpful to me, including the BBRF. My YI grant was extremely helpful to me in learning a lot more about borderline personality disorder and establishing a research program in this area. I also want to thank the folks at Yale who have been critical to my work in an ongoing way, including the many trainees in my lab, and I want to highlight Jacob Levitt, who spearheads a lot of the work I'm going to talk about today, and my mentors, Phil Corlett and John Crystal, the place where I work, the Connecticut Mental Health Center, and the Neuroscience Research Training Program that supported me during my residency training. Also, the people at McLean, especially Mary Zanarini, and the family advocacy groups, including Emotions Matter and Families for BPD Research, all of the many research participants and patients that I have had the honor of working with, and the American Foundation for Suicide Prevention, who are supporting some new work following from the YI grant. Today, I'd like to begin with a quick review about borderline personality disorder, and some of this will be familiar to those of you who attended my prior webinar 2 years ago, and I think it's important to get us all on the same page. We're going to talk about what BPD is, what we can expect over time, and what the current treatments are. And then we'll get into the science. And so again, today I'd like to talk about 3 examples of BPD science, and we'll focus on social experience, social worlds, and social interactions in BPD. So let's start with core symptoms. One nice way to conceptualize BPD is to think of it as having sort of 4 categories of problems. And this is a simpler way than the sort of 9 criteria in the DSM, where you have to have 5 out of 9 criteria. I find it easier to remember and sort of, I think it well encapsulates the whole syndrome. So let's start with affective here. The affective symptoms, especially, it's notable that in BPD, people's moods can change quickly from minute to minute or hour to hour. And Although people can have chronically, stably depressed or anxious mood, this changeable mood is really a criterion that distinguishes BPD from some other disorders like bipolar disorder, where the mood can change more slowly, or major depression, where the mood is more stable. Impulsivity, people with BPD can be quite impulsive, and to meet criteria, they need to have impulsivity in two different categories. Cognitive, this means the kinds of symptoms that are sort of like psychotic symptoms, being very suspicious of other people, like paranoia, even perceptual disturbances like hearing voices that other people can't hear, or feeling or seeing things that other people can't. The interpersonal symptoms, and I'm going to underline interpersonal here because I think of interpersonal symptoms as being a master switch. Difficult relationships with lots of ups and downs can lead to sudden and intense distress that increases the intensity of other kinds of symptoms, like a bad relationship problem can increase paranoia, impulsivity, and the changeability of mood. BPD is present in a lot of people, as many as 1 in 20 in the general population, and as many as 1 in 5 in psychiatric settings like outpatient clinics and inpatient hospitals. Borderline personality disorder is highly heritable, probably more heritable than major depression and less than schizophrenia, but we don't think it's biologically related to schizophrenia. Now let's focus on what happens over time. So in this graph, you can see that time is represented on the bottom axis here. So people who were admitted to the hospital at time 0 were put into a study called the McLean Study of Adult Development. And then they were followed over almost 16 years, and actually the study is ongoing now. And then the number of people who continued to have BPD symptoms were tracked. And remission meant people no longer met criteria for BPD, meeting those 5 of 9 criteria in the DSM manual. And so here you can see that almost a third of people no longer met criteria after just 2 years. And by 8 years, more than 80% of people no longer met criteria. So there are only a few people who at 8 years later still meet criteria for borderline personality disorder. And by 16 years out, almost no one still meets criteria. So people get better by that measure of not meeting criteria any longer. However, recovery, which is defined as remission, plus at least one emotionally sustaining relationship outside the family, and full-time work or school, so getting back in a full-time way out into the world, is less common. So here in the red line, we can see that recovery at each time point is about half as frequent as remission. And at 16 years out, a full 40% of people have not recovered. And it's this gap that I've marked in yellow between remission and recovery that has been a driving force for my interest in working on better understanding what happens in social life of people with BPD. People with BPD have a strongly distressing experience, and this has been encapsulated in this quote by Mary Lisa Johnson, who wrote a memoir called Girl in Need of a Tourniquet about her experience with BPD. And she describes here both how colors bleed like in paint, and she experiences this sense of spreading out, not knowing where her emotions and self stop and the people around her start. But also, bleeding out is a word to describe what happens when you lose so much blood that you die. And so here we notice that BPD is confusing and very, very serious. Because of how confusing and how serious BPD is, both people who have it and people who work to help them can be tempted to do something right away, do something that seems like it would help. And this can result in the prescription of lots of medications. So here you can see that antidepressants are frequently prescribed in BPD and continue to be prescribed over time, and that almost a third of people are on anti-anxiety medications, antipsychotics, and mood stabilizers. And there's good reason to try to address distress and try to work on symptoms, even though the data about medication efficacy is very recent, from about the last 10 to 15 years, is inconclusive. There's no FDA-approved medication for BPD as a whole syndrome, and practice guidelines for clinicians still recommend no meds in most cases. Polypharmacy, that means long lists of medications, are quite common in BPD, and they are inversely related to improvement, meaning the more meds, actually people do worse. However, that doesn't mean we shouldn't prescribe at all. Medications do work for the expected symptoms. So people who are having a lot of difficulty with their mood changing do well with mood stabilizers, and even with antipsychotics, a little less with antidepressants. People who are very impulsive do well with mood stabilizers and a little less with antipsychotics, and so on. So there may be reason to use medications because the symptoms can be so debilitating. But as symptoms fluctuate as part of the disease, it may be an important conversation to have between prescribing provider and patient about whether this is the kind of symptom that's changing so often that it doesn't need to be addressed today, or if this is the kind of symptom that's so debilitating that treating it would really help the person improve in other areas. Also, because of impulsivity, it's important to be attentive to which medications may be risky in an impulsive overdose. And it's important to treat the distress so that impulsivity and suicidality can decrease. So you can see that I'm arguing this is complicated, and prescribers and patients need to work closely together and to include the other people in someone's life who they want to include to try to help create a system around the use of medications. I also want to pause on the importance of the meaning of medications. Adding and decreasing medications for anyone, and maybe especially in BPD, can trigger strong feelings both about being a person who's judged to need to be medicated, also about being helped, and also about the possibility of having help withdrawn when medication lists are tapered. If you'd like to read more about this, I recommend the work of David Mintz, who's at the Austin Riggs Clinic. Psychotherapy is the mainstay of treatment for BPD. So though medications can be helpful and should be used in targeted fashion, psychotherapy is really where it's at. Good psychiatric management is a case management focused approach to try to help lots of clinicians, even those of us who may not have the time or energy or finances or access to expert treatments, to do a good job for people with BPD. If you're sort of a beginner, this would be a nice place to start. DBT is a psychotherapy that was developed by Marsha Linehan to focus on decreasing self-harm and suicide, and it's been well evidenced for that and other features of BPD. Also, transference-focused psychotherapy is helpful for addressing especially the interpersonal features of the illness that can promote ongoing problems. And mentalization-based treatment really focuses on helping people understand their own minds and those of others in a way that can ultimately change behavior and emotions. So all of these psychotherapies carry a good evidence-based, and it would be helpful to probably people and their families to learn more about them. For clinicians, if you'd like to learn more, there are great classes at the BPD Training Institute at McLean. There are videos of good psychiatric management online, and there are workshops at the APA. I also can't emphasize enough how important it is for families to be on board and learn tools to be helpful. And you can find resources for referrals at the BPD Resource Center. People who are affected by BPD and their families can join the anti-stigma efforts of Emotions Matter, which is a great organization in New York City with a wonderful online presence. There are additional resources through NAMI and family trainings through the NEA BPD and also through TARA. And the Personality Disorders Awareness Network is a nice organization that has lots of social media presence. Okay, so that's a quick introduction to BPD. Let's talk about science. We'll begin with how to measure social networks. People with BPD are at a social disadvantage. And one way of thinking about this is that If you're a person with BPD, you start out perhaps a little less trusting, a little more negatively biased than other people, and that leads you to have less successful social interactions, which then confirm your initial bias, and this can spiral out of control. One way of understanding this in a quantitative manner, trying to figure out who is around someone with BPD and what is the nature of those interactions, is actually to graph them. And so this is called social network analysis, and in particular, a really nice recent paper from Joe Beanie and others at Pittsburgh has described the networks of people with BPD using a kind of social network analysis called the egocentric network. And what that means is just it's a social network that's centered on one individual, in this case, a person with BPD. So what goes into the network? Well, first, you list the people who are significant in your life. Next, you ask, what is the nature and the quality of these relationships? And that's something that a person does by responding to questions that the experimenter asks about the relationships, like how close do you feel to other people? How much conflict do you have with them? Then we ask, how are each of these people in the network connected to each other? And so it comes together like this. First, who is the person at the middle of the network? So this would be the person that we're studying. Next, who are the alters? Alter is a word for the other people in the person's life, and that might be a friend, a mother, a boyfriend. Next, we connect the individual in the middle here, labeled ego, to the other alters with lines, and those are called edges. So the length of each edge represents the closeness between those two people. So this short line means that the ego said that the boyfriend is quite close, the mom is a little farther away, and the friend is emotionally the least close of the three. You can also mark alters according to other features. So in this case, maybe the dotted line means that the relationship with the friend has a lot of conflict. Then the computer can calculate features of the graph. So how connected is a specific person in the network? That's called centrality. Or how dense is the network overall? How connected is the network overall? That's called density. And so these and other features can be measured depending on symptom levels. And then a graph can be generated. And this is what an example of a whole graph from Beanie's paper. And you can see this is the middle. This is the ego, the person being studied. And then here, A, this is a person who's highly connected in the network. There are lines going from this person to lots of other people. And so we might actually call this person a hub. And then this one here, B, is someone who is barely connected to the network. The only connection, in fact, that this person B has is to the person that we're studying in the middle of the network. So what Beanie found is that BPD symptoms are associated with reduced closeness, and this is the math describing the social networks across the data set. Here you can see that there's a negative association with each of the subsets of closeness and support. So the more BPD symptoms that you have, the less closeness and support that you experience. And the more BPD symptoms that you have, the more negative interactions that you experience. Another example of data from this paper that can be derived from this kind of modeling is that they divided the people who had BPD traits into low BPD, those who didn't have very many traits, and high BPD, the people who had many more symptoms. And then they graphed the results. So let's zoom in on this first one here. So what you can see is that people in the low BPD group, that's this solid line here, are having romantic partners who are more connected in their networks. These people have a lot of centrality. But people with higher BPD have romantic partners who are more isolated in their networks. They're less connected to the other people that belong to the network. Also, people who have the high BPD features spend a similar amount of time with people who are not romantic partners as do the low BPD people. But when you look at the romantic partners, people with high BPD spend a lot less time with their romantic partner than do the people with low BPD. Also, in terms of how attached people feel to their partner, we see something similar. People with high BPD feel less attached to their romantic partner than do people with low BPD. Oh, I jumped forward. Even though for non-romantic partners, those people feel similarly attached. Lastly, for control subjects, relationships that are more central, so if we go across from people who are sort of not so hub-like, less central, to people who are more hub-like, more central, control subjects have more positive experiences going up this black line as people become more central. They also have more conflict here. And that makes sense. It's people who you spend more time with, who you're more involved with, who are more involved with the other people in your life, you're more likely to have experiences with, be them positive or negative. However, BPD subjects have the same low level of positive experiences no matter how central someone is to their network, even though they have more conflict at actually every level of centrality than do control subjects. So they're having fewer positive experiences with all of the people they interact with and more conflict throughout. And all of their relationships have more conflict than controls all the way along. So in sum, social networks can provide webs of support, closeness, and connection with the people in our lives. But people with BPD can have social worlds that are less supporting and more conflictual than control subjects. And so one of the things that we would want to know going forward is how social networks can describe the kinds of interpersonal challenges and also describe the kind of change that people with BPD are capable of. So we'll be interested in studying how social networks relate to trust, cooperation, imagining other people's minds, interpersonal sensitivity, and especially the ability to change social beliefs over time. Another question is how people with BPD engage with social approach and closeness. And one way to think about this is to really literally think about physical approach and physical closeness. So when I started imagining this, I thought back about an experience I had when I first moved to Connecticut. And I would drive to New York along the Merritt Parkway, which you can see here is really beautiful, and I would feel just wrong. And I wasn't sure what was going on until the first time that I went home to the Midwest, and it looked like this. And seeing that big open space made me realize that I have this strong preference based on my childhood experience for being in this wide open area. And most of us have clear preferences about our physical environment and closeness of objects and people. And this dates in our evolution back very early, and there's good reason for it. Rodents prefer shelter because being in an unsheltered space, you can get found and it's risky. Anxious rodents explore the world even less and are even more avoidant of being exposed. And this can be studied in the laboratory in what's called an open field test. So we might place a mouse in a big open box, and then we let them walk around for maybe 10 or 15 minutes. And when we do that, we can track where they walk around in the box. And what we find is that control mice that are not affected by symptoms, move around the box all over, check out the whole space. But anxious mice ring the edges of the box, almost wearing out the floor in an effort not to be exposed in the middle of the box. And scientists can quantify this by measuring the intensity of the path signal in the outside marked E in both diagrams and the middle, which is marked B in both diagrams. And you can see that if we were to compare the intensity of the signal at the E, as E is for elephant here, on the outside on the control mouse and the anxious mouse here versus here, there would be a clearly stronger signal here on the anxious mouse for staying on the outside of the box. And this also is a shared experience for people. So take a moment and imagine yourself living in the country in the middle of nowhere, or standing in the middle of an empty stadium, or maybe standing in an elevator that has stopped between floors. And when you do this, I imagine that some of you have a strong experience of feeling out of sorts. And this can be also quantified in a similar fashion. So Walt and colleagues asked people to stand at the edge of a stadium, a soccer field, and to move around however they saw fit. And they tracked the path. And control subjects, people without mental illness, moved around and checked out the stadium and looked at the grass. Anxious people ringed to the edge of the stadium, barely entering, except for this one deviation, the middle. But what happens if we add in other people? So now imagine you're going to throw a free throw in front of a large crowd, or give a speech to a big audience. Or maybe you're going to walk through a crowded market and try to buy some tomatoes. Or you're going to sit in the middle of a crowded movie theater. These experiences might evoke a much stronger response for you than just the empty rooms or elevators. And experimenters have also figured out how to measure this. And so they asked a person to stand still on the floor, and then an experimenter walked toward them closer and closer and closer and closer. And then the subject, the person here, was asked to say stop when it felt too close. And subjects without mental illness chose a range of distances, but most of them were about an arm's length away. When a person who was missing the fear center in her brain, the amygdala was missing, was asked to do the same thing, she chose a much closer distance. And experimenters began to wonder for this reason, if this person missing the amygdala didn't have the same ability to regulate interpersonal space, and if maybe the amygdala was an important brain center for doing that. So they repeated the experiment in the MRI scanner and said someone is getting closer and closer and closer. And in fact, they saw that people who did have an amygdala had specific activation of that region of the brain. So we think that the amygdala then is important for regulating personal space choices. And we know actually that the amygdala is very strongly activated in borderline personality disorder, and that it may be responsible for some of the negative attribution bias, meaning the amygdala may be responsible for the negative ideas that people with BPD bring to social and other situations. So we have this hypothesis now that we've set forward that the amygdala hyperactivity interacts with interpersonal behavior in BPD to alter behavior, that people may be more negative in interpersonal interactions because of how strongly their amygdala is activated. And we wondered, is preferred social distance a way to measure amygdala activity or maybe negative attribution bias in BPD? And so we decided to start with a first step, and we tested, do people with BPD choose a different distance than do controls? And so this is the first paper that I've been able to publish out of the NARSAD work. And what we did was we brought in 30 women without mental illness and 23 women with BPD, and you can see that they're middle-aged people, about matched on age and education level and reading, and none of the controls were taking any medication. About half of the people with BPD were taking various psychotropic medications. And if you look here at the line that says mean, you can see that borderline symptoms were fewer in control than BPD, same for depressive symptoms, anxious symptoms, and impulsive symptoms. And we looked at preferred social distance. So people in the control group preferred this distance of about 12 inches from the examiner. People with BPD preferred a much larger distance. The expected finding here was that people with BPD, because of their amygdala hyperactivity, would prefer a larger distance, and they did. They preferred this distance more like about 22 inches, and this was statistically separable from the control behavior. So what we found is that people with BPD prefer a larger social distance, and this really leads us to some future questions, which are, does preferred social distance change with familiarity? Would people have acted differently if they knew us or if the person was a friend or a romantic partner? Does it change with social difficulty when people are upset? Will they get too close? Will they stay too far away? And does it change with treatment? And I'll come back to this question at the end. So now we're on to measuring social decisions. And as we're thinking about social decisions, we want to think about, how do people get ideas? How do they hold on to them? And we would call that learning. So let's just take a look at all learning. We'll step away from the social for a moment. And what we know from a small body of work is that people with BPD do have some deficits in working memory. And working memory is basically what you can hold in mind for a brief time. So you learn something and you kind of hold it in mind while it's getting settled into your brain. So, say that you plan a list of 10 items to go to the grocery store, and then you forget your list and you go off to the grocery store. How many can you hold in mind on your way there? Reversal learning then is, can you change your mind? Somebody calls you on the way to the grocery store and said, scratch that, we don't need tomatoes and basil, we actually need blueberries and oats, and you have to really work hard to unlearn what you learned before and learn something new. That's reversal learning. And then acquisition is just the process of learning. So working memory does have deficits in BPD in a small paper. 2 papers suggest that reversal learning is not impaired and that acquisition is not impaired. So what do we know about social? Well, predictions from the clinic and from our experience might suggest that people with BPD bias to extreme views, extremely positive views, or extremely negative views about other people. And that changing your mind once you settle into a negative view, if you have BPD, might be really difficult. So here's a way to quantify that. This is called the trust game, and this is an experiment that was done by Reed Montague and his team. And what happened was that a subject was assigned to be an investor, and that was a control subject in this setting. And the investor gets $20. And then the investor decides how much of the $20 he wants to share with our subject. And this is where we're going to see the behavior from someone with BPD. So the investor shares part of the $20, and what happens is that amount triples on the way to the trustee. So if they shared half $10, then the trustee gets $30, and then they decide how much they want to give back to the investor, anything from 0 to all of it. And so because of the tripling and the return, there's something in it for the investor to make investments. And because the trustee knows that there will be multiple trials of this, 10 rounds in the game, the trustee has something in it to return something so that the investor will continue to invest. What was found was that when the trustee was someone with BPD, compared to when the trustee was someone who was without BPD, they behaved differently. So if the investor started to get the sense that this was an unfair game and stopped investing, control trustees returned too much on the next round in order to sort of coax the investor to invest more. And you can see that not everyone did that, but about 45% of people did that under those circumstances. Only half as many trustees with BPD did this coaxing to get a defecting partner back to play. Also, when the control trustees got bigger investments from their partners, their amygdala quieted down, so that fear-anger center in the brain was able to be readily calmed by a cooperating partner. But in BPD, the amygdala signal remained variable and sort of all over the place at a fairly steady level, despite bigger and bigger investments. So it was almost as if the amygdala could not detect the change in investment from the partner. And that was really helpful, but it's still unclear here what is driving this change in coaxing or what may be going on. So in the last few weeks, Montague's team has published a new computational model of this social behavior that describes in more detail what may be happening. And when they built this model, they discovered 2 features more than the previous ones that they had examined that influence behavior, and this is because of the complexity of the computations. So they were able to find that risk aversion matters. So how much people avoid sort of putting themselves out there versus how much they're willing to. And also a parameter that they called irritability. And this is how much a person retaliates when their partner doesn't give as much money as they thought was fair. And then even more interesting than irritability on the part of the trustee, and that's our BPD or control player, is how well the BPD or control player seems to be able to imagine how irritable their partner is. And in fact, they got so interested in this question of figuring out their partner's irritability that they named the 4 levels. So if you don't have any idea how irritable your partner is, they called that ignorant 0. And then you can see in the middle here, they call realistic if you sort of think your partner might be irritable. And then fatalistic is if you're really convinced that your partner might be irritable. So how do we think about this on a sort of trial by trial basis? Let me walk you through it. So here on the y-axis, we have the 10 trials of the game. And here, that's the x. And here on the y-axis, we have how much of the available amount was returned. So we start here with the blue line, and this is the amount that the investor invested. So the investor tried to be fair and invested exactly half of what they got. And then the trustee, here in red, gave back a lot less. And you can see that then the investor thought, oh, maybe, or we can imagine that the investor thought, oh, maybe I'll give more and I can kind of get them into it. But what happened? The trustee gave even less. And at this point, we can look at this black line and you can see that the investor irritability spikes. The investor plummets in the amount that she gives on this trial. But now the trustee gets it. He gives more. And then irritability is able to fall. A repair has occurred, and you can see that both the trustee and the investor remain at medium to high levels almost until the end of the game. That's an early rupture that was able to be repaired. In this case, however, the same thing happens at the beginning of the game. Investor gives a fair amount, trustee gives a little bit, investor tries giving more, trustee gives even less, investor gets upset, trustee gets upset, neither one of them recovers, and irritability on the part of the investor spikes and stays high for the rest of the game. So this is an example of rupture without repair. And when we look at irritability and irritability beliefs about the partner in borderline personality versus control subjects, we see some really interesting things. So the features that most distinguishes BPD trustees from control trustees in these more complex computational models were people who appeared to not notice that their investor partner was irritable, were much more frequent in the BPD group. So if we just count up the number of BPD trustees versus the number of control trustees at each level of awareness, the BPD trustees are much more likely to be unaware, or we called it ignorant here, of their partner's irritability. And that represents potentially a missed opportunity to notice that there's something wrong and then go ahead and coax the partner back to play. Also, they have this parameter, and I want to be careful about this word here, guilt, but guilt is a sort of computational parameter here to describe how well the trustees respond to unfairness. And here the BPD trustee has lower levels of guilt. There are more of them in the 0 level guilt box than there are control trustees. So these two differences were mathematically significant and may help us understand better what's going on with that observation that people with BPD coax less. So in sum, people with BPD cooperate less with their partners in the economic exchange game. The amygdala signal in trustees decreases with bigger investor investments in controls, but the amygdala signal does not decrease when the investments are bigger for BPD trustees. They have a hard time noticing that someone is showing up and trying to work with them. people with BPD coax their defecting partner less. So when someone is starting to leave, they're less able to, in this game context, help the person come back to play. And that may be because they don't notice their partner's irritability when the early signs are present, and they don't act to change their behavior. So now I'm going to talk just briefly about a new study that we're really excited to be doing in my lab, and this is about ketamine, which is a medication that's long been used in anesthesia for children and adults, and many of you may have heard that it rapidly decreases depression and suicidal thinking in people who have major depressive disorder, and I'll just show you here a little data about that. So the blue line is tracking people's depressive symptoms after getting a placebo infusion. And you can see that over time, the early minutes and the 2 weeks after infusion of ketamine, which is an IV administered medication, that people have stable depressive symptoms. But if people are administered intravenous ketamine, their symptoms fall rapidly within 1 hour, and they remain with lower levels of depression out past the 1 week mark here. But we don't have any data about whether people with BPD will get the same benefits from ketamine for either depression or suicidal thinking, or sort of what it will be like for people as the treatment starts to wear off here. So in animal models of depression also, ketamine induces neuroplasticity. And just to take a side note here, neuroplasticity means nerve cells making new connections and nerve cells strengthening new circuits, and this can promote new learning. So neuroplasticity is particularly exciting when we're interested in how to help people change. And this increase in neuroplasticity lasts for about 3 days in animal models after ketamine. We don't know how much or how long in people, but we hypothesize that this post-ketamine neuroplasticity, if present in people, may offer an opportunity to revise old social beliefs. And based on what we've been talking about today, you can imagine I think this is very exciting. So we have established a new randomized controlled trial of ketamine versus placebo for adults with borderline personality disorder. Each participant in the study gets 1 dose, either a dose of ketamine or a dose of the placebo. And then we'll follow several outcomes: suicidality over time, the evolution of mood symptoms over time, BPD symptoms, pain, because ketamine's an anesthetic, and social functioning. And the study looks like this. So we'll enroll about 60 people over 2 years, and a third of them will be in each of 3 groups. Midazolam is our placebo. Low dose ketamine is the usual depression infusion dose of ketamine, and very low dose ketamine is half that dose. And then we'll follow people, you can see, at a range of time points for a month to see how they do on each of these outcome measures. We're particularly interested in real-world social experiences following the EgoNet as people pass through the study, social distance, and the trust game. And so all of the things that I've talked about today will be outcome measures in this new study. If you're interested, or you know someone who might be interested in this study or other studies of borderline personality disorder, I really encourage you to go to clinicaltrials.gov, search for borderline personality disorder, and you can find our study and several others that are recruiting subjects to learn more about best practices for treating BPD. So in sum, we've talked today about BPD, what it is, the 4 symptom clusters, the prognosis that many people remit and fewer recover, and that's a driving force for the things we need to learn more about. And what are the current treatments, including psychotherapies and medications, also family interventions. We've talked about how we can quantify aspects of social functioning in terms of social networks, social distance, and social exchange. And we've talked, just hinting at the new study, ketamine in BPD, and encouraging you to check out my research and other people's at clinicaltrials.gov. So that's what I wanted to talk about today, and I hope that we can have some conversation about this and other questions that you may have.
Well, Sarah, thank you so much for an excellent presentation. that really is user-friendly for a lay public, but filled with information. I want to ask you a question, and a few people have brought this up in different ways, which is, how can a family best provide support to a loved one who has BPD?
Oh, I'm really glad that you asked that. I think it's a really important question, and it doesn't get as much focus as maybe it should. So one thing is, I think to start, families can learn more about the disorder. So those of you who are here today, thank you for showing up. And families can also get involved with the family organizations to get support for themselves and support in understanding the disorder so that they can best help their family members. They can communicate clearly. One of the things that we know in BPD, and we've been talking about a lot today, is that the social world can be confusing in BPD, and that ambiguous signals like talking to someone in a way that isn't absolutely clear might be really more confusing. And so I think it's really important to say, I laughed right now because I thought what you said was funny, not so much because I'm making fun of you, or other things like that. And I think the same thing can apply to angry situations, communicating simply and clearly. And you can learn these and other techniques by attending the workshops that NEA BPD and others put on to help family members get support for themselves and learn about BPD, learn to work with their family members. You can support your family member to get into an evidence-based treatment for BPD, get a good diagnosis, and get into treatment. You can reach out to the BPD Resource Center to learn about good treatment. And you can ask your family member what would be most helpful to them in maintaining safety and improving emotion regulation and experience over time.
All good advice. You spoke a little bit about medicine and the fact that often people get too much medicine. They may need some medicine, but often polypharmacy, that's too much. I want to ask you a little bit about talk therapy.
Talk therapy, yes, please.
Yes. Tell us what are the most effective methods of talk therapy for somebody with BPD?
Yeah, so if it's okay, I'm actually going to try to see if I can take us back to that slide so that we can look at them while we talk about it. I think talk therapy is so important in BPD. It's by far the most effective way to help. And it requires a significant investment of time and energy, and it's worth it. So I would say that for people with BPD, there are a range of options, and you would choose what kind of talk therapy to get into based on what's available in your area and what's a good match for you. So it's good to learn a little bit about each of these kinds of talk therapy. Some of them are more focused on behavior, so what you might do, and some of them are more focused on emotions, so how you might feel. But all of them, I think, at this point, ask that you get out into the world and engage with other people and with work and with school, and would encourage you to feel capable and effective. Good psychiatric management is a really nice approach for clinicians, as I said before, who might not have very much experience working with BPD but would like to get better because it's very accessible. DBT is very well manualized and available in more communities, I think, in the country than almost any of these other techniques. So that may be one that's more accessible and also is very well evidenced. And for those of you who are more used to talk therapy that's more about emotional experiences and interpersonal experiences, you might find TFP or MBT, the latter two, more familiar. But all of these are very good approaches to treat BPD, and I think the trick is to get into one and find a therapist and team you can work with. The other thing I'll say is that many of these are deployed in groups, and some of you may feel that a group would not be a comfortable place to get treatment, and I think that's a common feeling, but I'd really encourage you to go and try anyway, because sometimes groups, and especially groups of people who have shared experiences, may be actually more effective than working with an individual therapist, even if it feels very uncomfortable at the beginning.
Thank you for that overview. I want to bring up the important issue, and you touched upon it in the presentation, of suicidal ideation, suicide risk,
Yes.
and which is such an important issue. And I'd like you to say a little bit about the issue of suicide and BPD.
Yes. So I'm really glad that you brought that up also, Jeff. I think that we should not take lightly the suicide risk in BPD. The likelihood of completed suicide in BPD is 50 times that of people in the general population. And I think that this can cause us, well, actually, the presentation in BPD maybe can cause us to either underreact, saying, oh gosh, people with BPD are cutting themselves or they're hurting themselves, but they're not really suicidal. That would be concerning to miss that people can have both non-suicidal self-injury and also suicidal thinking and action. And the other extreme would also be a mistake to be overimpressed by non-suicidal self-injury and clamp down on people who do have non-suicidal self-injury and may not be intending to hurt themselves. So one of the things that I think has improved in treatment in the last few years is willingness to talk about and willingness to have detailed conversation about suicidality. My understanding is that the best way to protect against suicidality is to talk openly about it. Family members and clinicians should know that asking people is not going to suggest anything that they haven't thought of, and also is not going to increase risk. In fact, just the opposite. So if you suspect that one of your clients or your family member may be at risk for suicide, I strongly encourage you to ask them, and to ask them often, and also to work with them on developing a proactive safety plan. And this can be a living document that you edit over time as you figure out what's helpful when you're feeling a little bit bad, what's helpful when you're feeling a medium amount of bad, and what's happening when you're in the kind of crisis where you can't think anymore. And it's good to make a plan like this and to keep it in your pocket and to give it to the people you care about if you're a person affected by suicidality. And although we don't know nearly as much as we need to about protecting people, I think that having open conversation about suicidality and asking details about what it's like to feel that way, and what it's like, what kind of a plan the person might have, and how far they've gone down the path of having a plan is the best we can do now, and it's a lot.
I think you make such important points. It's so important I'm going to emphasize it, because many people believe that asking about suicide may increase the risk, give the idea, when we know there's clear evidence that asking about it actually saves lives, and it's important if you're concerned to ask about it. So I'm just reemphasizing what you just said.
Thank you.
The other issue that's important in all of psychiatry, but in many ways more for BPD than anywhere else, is the issue of stigma and prejudice against people who have these conditions. And I'd like you to speak about the issue of stigma and BPD.
Stigma can be so painful. And I think especially as we get more comfortable as clinicians and in society at talking about BPD and people with BPD-like traits and how devastating it can be, there's actually an increased risk that a clinician or a patient can be surprised by stigma, which can be devastating when you've gotten a diagnosis maybe that makes sense to you and you're feeling good about working on it and getting treated, and then maybe you go to a setting where they're less familiar with the disorder and they see it in another way. Or you maybe go to the emergency room and somebody talks about BPD in a way that makes you sound manipulative or unkind or just angry, or as if you're doing this on purpose. And so I think that we have a lot of work to do to help all kinds of medical providers and people in the general community know about BPD and know that it's real and that it has a biologic basis and that it can be treated. And in fact, the prognosis is really good for remission, as we saw at the beginning of the talk. And so I think that that's work that we're doing through the BBRF and Families for BPD research and increasing access to research for young investigators. And that's been really important to me, and I know several of my colleagues, in being able to put together work like this. And also, I think it's really important for the work that's been going on through organizations like Emotions Matter in getting people who have BPD out there feeling proud of getting better, feeling proud of talking to each other and supporting each other, and talking to people in the general community about fighting stigma. And actually, I wanted to do a shout out to Emotions Matter. They're putting together a really nice walk for BPD in New York City in May. And so I encourage you to check out their website and get involved with the walk, which I know I'll be proud to participate in.
I'm going to ask one more question, and that relates to the issue of substance abuse, substance misuse in people with BPD. Can you tell us a little bit about that important issue?
Yes. So I would say that substance use and misuse is common, and I think this speaks partly to impulsivity and partly to distress. We've talked a lot today about how isolated and how overwhelmed people with BPD can feel. And one path into substance use and misuse is social isolation or social awkwardness or anxiety. And so I think that we should be aware of the sort of paths in to substance use and misuse. We should be aware of the kinds of prescriptions, like prescriptions of addictive substances, which can be high risk for people with BPD. And we should be aware that when we're thinking about treatment strategies, it's important to be clear about whether someone is in a place to do psychotherapy. So sometimes someone comes in with BPD and a substance use disorder, which is severe enough that it either looks like BPD when it isn't, because someone's intoxicated, leading to emotional lability and impulsivity and other features. And so it's important for someone to get sober. And also, it's important for someone to have the supports to stay sober that can help them really engage in the psychotherapy. So I would say BPD can be a risk factor for substance use disorder, and also substance use disorder can either mimic or get in the way of BPD treatment. So we need to be screening for and addressing those substance use disorders in order to really be able to get at and do the work to help people who have BPD.
Well, Sarah, our time is just about up, so I'm going to say thank you so much for a very interesting, informative presentation, and more importantly, thank you for the research that you're doing, which will have an impact on so many people's lives. So thank you for that.
It's really been a pleasure. Thank you so much, Jeff.
You're welcome. I also want to thank Families for BPD Research and all people that have been supporting research in this important area that had been neglected for so many years. And we hear from Sarah the impact that research will have on the treatment for this condition. I also want to thank everybody who joined us today for the presentation. All of the research we fund is made possible through private donations, so please consider making a contribution by visiting bbrfoundation.org or call us at 800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it with a family member or friend, please visit the events and webinar page at our website. I hope you'll join us again next month when Dr. Mark George, Distinguished Professor of Psychiatry, Radiology, and Neurosciences at the Medical University of South Carolina, will present What's New with TMS for Depression and Other Brain Disorders. This webinar will take place on Tuesday, April 10th at 2 p.m. Eastern Time. Thank you again for joining us, and enjoy the rest of the day. Take care.